So you got an acidotic DKA patient and you hear that their initial potassium was 3.8. The patient's already gotten insulin and you're wondering, well, do I need to give them potassium or not? When I give this presentation, I'll say, is this 3.8 milliequivalents per liter? Is this in the cells or outside the cells?
I'm out.
And most people go, well, that's got to be outside the cell, right? It's not like we can actually put this needle that we're drawing blood from into the cell. So we're drawing the serum potassium or the extracellular potassium. And if you look at this little graph here, I have the intracellular potassium and then the extracellular potassium, the serum potassium. And so you can see inside the cell, the potassium concentration is somewhere between 120 to 150 milliequivalents per liter. And then outside the cell, normally you see potassium somewhere around 3.5 to 5.5, significantly less. Well, we know when a patient becomes acidotic, specifically in like a DKA patient, where you have increased amounts of ketones, beta hydroxybutyrate, it causes the cellular permeability to allow some of that potassium to leak out. And we know we also have this shift of hydrogen ions going into the cell and kicking out potassium. And so what ends up happening is we see that intracellular potassium start to come down, and then you see your extracellular potassium or serum potassium start to increase. And if you were to just stop right here and say that the patient does not have the ability to urinate, maybe they're in renal failure, then you would expect that patient to be hyperkalemic in DKA. However, we know that if they can urinate, what's going to happen with the DKA patient is they're going to become polyuric, right? You're going to have this polyuria that causes them to pee like a crazy amount. And so as they pee, you start to see the serum potassium start to drop. Now, when you give the patient insulin, what that's going to do is grab a hold of that glucose, because there's, let's just say their glucose is like 500 or so. It's going to start putting that in the cell, but it's going to take potassium with it. And the body's going to try to replenish this intracellular potassium first to try to get this back to norm, and then we can get this one back to norm. So if you're giving your patient insulin and their potassium was within a normal range, you're going to have to give them potassium during that infusion. And it's a smart idea to just take a 20 milliequivalent bag of potassium with you, especially if you're going to draw labs in transport, and then all of a sudden it comes back and you got a low potassium, and then you got to stop the insulin because you can't keep that going. And so that kind of puts a roadblock in the whole process. Now, if your patient does have renal failure, they're not able to urinate, well, then you would see that potassium start to increase. And so I think this sometimes could be a point of confusion with DKA, that there's a tendency to think that the potassium should be high because they're acidotic. And we know that that creates a shift in the potassium from intracellular to extracellular. However, depending on where you meet this patient in their journey, that could be happening, or it could be that they've already urinated out all of that potassium and their potassium is either low or normal. And so as you give them that potassium, you want to replenish it, but also keep in mind, you got to fill back up the intracellular, and then you can start to fill up the extracellular.